بسم الله الرحمن الرحيم. محاضرتنا اليوم عن Ante Partum Hemorrhage APH. Ante Partum hemorrhage is defined as bleeding from the genital tract after 20 weeks of pregnancy and before the onset of labor. Incidence in about 2 to 5% of all pregnancies. From the beginning, we must know that a digital examination should not be conducted until an ultrasound has been identified the location of placenta. This is very important, especially when we have suspicion of case with Placenta Previa. What are the causes? There is maternal and fetal. Maternal, Placenta Previa, abruption, local causes in the vagina and the cervix, blood dyscrasia, cervical erosion, genital tract infection, undetermined causes, while fetal causes, vasa previa. Now we will talk about placenta previa. A placenta which implants wholly or partially on the lower segment of the uterus. Risk factor of placenta previa: multiparity, multiple pregnancy, increasing maternal age, prior cesarean section or uterine surgery, smoking. We classified placenta previa into two classifications. Grade 1, the placenta reaches the lower segment but not the internal os at about 2.5 to 3 cm away from the internal os. Grade 2, the placenta reaches the internal os but does not cover it. Grade 3, the placenta covers the internal os before dilatation but not when dilated. Grade 4, the placenta completely covers the internal os of the cervix even when dilated. This is type 1 classification. So there is another classification which is classified according to what? According to ultrasound classification, minor and major. Minor include grade 1 and grade 2 that we said in the previous slide, and major include grade 3 and grade 4. Here, as you see, this is grade 1, placenta, 2.5 to 3 cm from the internal os. Grade 2 reaches the internal os but not cover it. Grade 3 cover it when it is closed but not when it is dilated. This is grade 3 placenta previa. Grade 4 completely covering the os even when it is dilated. Placenta previa can be associated with malpresentation, pre-labor premature rupture of membrane, intrauterine fetal growth restriction, and there may be also increased risk of congenital anomalies but not specific one. There is a risk that the placenta implant into and thus invade into the previous scar, and this is called as a morbid adherent placenta. And there are 3 types: placenta accreta, inaccreta, and per accreta. Placenta accreta, placenta is abnormally adherent to the lower uterine wall and there is no decidua basalis, and the fibrinoid layer is incompletely developed. This is called acrite. Placenta inacrite. Placenta is abnormally invade into the uterine wall, myometerium. Placenta peracrite. The placenta penetrates the myometerium and may invade nearby viscera. Presentation: either asymptomatic and are diagnosed by routine ultrasound, or painless bright red vaginal bleeding. 10% of all women with placenta previa will reach term without an episode of bleeding, or persistent malpresentation or high height in late pregnancy. Diagnosis: ultrasound, MRI, angiography. Now we'll talk about management. Asymptomatic low-lying placenta. All women with low-lying placenta diagnosed in early pregnancy should be rescanned at 34 weeks of gestation. Advise the pregnant woman to avoid stressful work. Keep the woman HB hemoglobin level above 10.5 gram per liter. With bleeding. Here, very important. This is the ABC because it's an emergency condition. And any case presented with bleeding, this is the ABC management for it. Then subsequent management is dependent on the gestational age, stability of the mother and the fetus, amount of bleeding. Delivery is always indicated in if there is a non-reassuring fetal heart rate despite resuscitation effort, if there is life-threatening maternal hemorrhage, if gestational age is more than or equal 34 weeks and there is non-fetal lung maturity, if there is persistent bleeding or persistent uterine activity. At 36 to 37 weeks presentation, a final ultrasound should be performed and acted upon. Grade 3 and 4 placenta previa should have a cesarean section between 37 and 38 weeks of gestation by experienced obstetrician, particularly if the placenta is on the anterior wall of the uterus. In all cases, the operating room should be prepared for the possibility of a necessity to perform a hysterectomy. Now we'll talk about placental abruption, the other cause. First cause, 1/3 of the causes of APH is placenta previa. The other 1/3 is placental abruption. Abruptio placentae is defined as a premature separation of the normally implanted placenta. Look, normally implanted placenta from the uterine wall after 20 weeks of gestation, but prior to the delivery of the fetus. It may occur as an antepartum or intrapartum event, either antepartum, let's say before delivery, or intrapartum during delivery. Pathogenesis of abruptio placentae may be the end of a chronic vascular pathological process, may be due to a single initiating event as abdominal trauma. Here the classification of abruption of placenta, as we see here: external abruption, that's to say the bleeding is coming out from the uterus; relatively concealed abruption, partially concealed. Here concealed abruption, that's to say there is bleeding but it is not coming from the uterus, just inside. This is called concealed abruption. Here also, this is the external bleeding, this is the placenta, while here is internal bleeding and this is the placenta. Classification: placental abruption classified into major and minor. Major is the clinically obvious and may result in the death of the fetus. It is also life-threatening to the mother and usually involves separation of more than 1/3 of placenta. 1/3 of placenta. Minor, premature separation of a small area of a placenta may result in placental infarcts. Several small abruptions may precede a large abruption. Much of the bleeding that occurs from the abruption is not discharged through the vagina and it is known as concealed hemorrhage. Etiology: the causes of abruption are not known, but the following factors are associated: hypertension, multiparity, trauma as external cephalic version or seat belt injury, domestic violence, and blunt abdominal trauma, decompression of overstretched uterus as in polyhydramnios, multiple pregnancy, at the time that the membrane ruptured, previous placental abruption, this increased the risk by 2 to 3 times. Smoking is associated with a significant increased risk. Strong association with the maternal age among all levels of parity. Acquired or inherited thrombophilia may be associated with increased risk. And there is well association risk between cocaine abuse and placental abruption. Clinical presentation: most placental abruption will present with the clinical triad, although many will not fill all three of the following categories. But what are the clinical triad? Uterine bleeding in case of revealed hemorrhage and shocked in case of concealed. Tetanic uterine activity or contraction, tetanic uterine activity. Fetal distress, and it is typically the first sign among patients who have continuous fetal heart rate monitoring during abruption. What about the presentation? Regarding major placental abruption, women present with abdominal pain and varying degree of shock. The blood loss that is visible revealed hemorrhage is often less than the degree of shock. And on examination, the uterus is woody hard due to tonic contraction. The fetal part cannot be felt. The fetus may be dead. While in minor placental abruption are often not diagnosed until after delivery, and there may be present with mild abdominal pain associated with the threatened preterm labor, unexplained APH, tenderness over one area of the uterus only. Complications: severe abruption may result in shock from blood loss, disseminated intravascular coagulopathy, oliguria or anuria due to hypovolemia. Minor degree of placental abruption may result in impaired fetal growth and or hypoxic ischemic encephalopathy, cerebral palsy. Management. Major placental abruption is a life-threatening condition for both the mother and the fetus. If the fetus is still alive, insert 2 IV large bore IV cannula and infusion of a normal saline colloid. Send 20 ml of cross-match for 4 units of hemoglobin and coagulopathy studies. Perform an immediate cesarean section if necessary to save the fetal life. And there is a high risk of postpartum hemorrhage. Ensure adequate fluid replacement following the cesarean section. Leave indwelling urinary catheter to monitor the urinary output. Consider insertion in a central line to monitor maternal intravascular volume more closely. If the fetus is dead, then the woman should be allowed to deliver vaginally, but also with resuscitation. Epidural analgesia is contraindicated because of the risk of coagulopathy, but a patient controlled of opiate infusion can be used. If a coagulopathy has developed or the woman starts to bleed, she should be managed in the following manner as in conjunction with the consultant hematologist, and we give her 4 units of fresh frozen plasma, and we ask the blood bank to get 6 units of platelets ready. Here there is a comparison between placental previa and placental abruption. In previa, there is no predisposing event, while in abruption maybe there is a predisposing event. Previa not associated with increased blood pressure, while abruption associated with increased pressure. Previa painless bleeding, abruption painful bleeding. Distress here, unusual distress here is common. In previa there is abdomen soft and non-tender, while in abruption there is tender, tense, woody. Fetal parts palpable. In abruption may not feel the fetal parts. In previa abnormal lie or presentation, while in abruption usually cephalic presentation. CTG is normal, here the CTG is abnormal. In previa coagulopathy late, while abruption coagulopathy occur early. Other local causes of bleeding in late pregnancy. Urinary or anal bleeding may be reported as vaginal bleeding in error. They need exclusion and their own treatment. Other causes are cervicitis, vaginitis, cervical polyp, cervical ectropion, varicosity of the vagina, cancer of the cervix, rare but important, confirmed diagnosis by biopsy. Blood dyscrasia. There are extremely rare. Bleeding may be seen in the following conditions, as in idiopathic thrombocytopenia, von Willebrand disease, leukemia, Hodgkin disease. Management. These conditions are usually known before pregnancy and should be managed in conjunction with a specialist. We will talk about fetal bleeding, which, as we said, vasa previa. This occurs from rupture of vasa previa when there is a filamentous insertion of the cord vessels and these cross the cervical os. Diagnosis. This condition usually present with the scanty bleeding at the time of membrane rupture. It may be associated with alteration in the fetal heart rate, producing a sinusoidal pattern. Sinusoidal pattern. If there is time, the blood lost can be checked for fetal hemoglobin by its resistance to alkalinization (Clyawar test). Alternatively, the condition may be suspected when an ultrasound examination reveals the presence of a 6-centroid loop of the opposite side of the internal os to the placenta. Management: deliver the fetus as soon as possible and prepare to transfuse blood to the neonate. Here, as you see, Placenta Previa, filamentous insertion of the cord. Thank you for listening.